Hi, everybody. Good morning, good evening, good afternoon, wherever you are. I'd like to welcome you to this new broadcast of the Journal Club of the International Academy for Clinical Hematology. It's 7 p.m. here in Paris, 7 p.m. in Nice, and it's noon in Nashville. So I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris. And it is my great pleasure to moderate this journal club for the IACH every 15 days. Here I'd like to acknowledge Takeda Oncology for their unrestricted educational grant for this activity. And today, the scientific committee has selected this article recently published in the Lancet Hematology. The title is CPX-351 versus 7+3 cytarabine and daunorubicin chemotherapy in older adults with newly diagnosed high-risk or secondary acute myeloid leukemia. 5-year results of a randomized open-label multi-center phase 3 trial. So you can see the summary or abstract of this lovely work, and I think the authors should be really praised for providing this long-term follow-up, because usually we have the initial publication, but then we rarely see the long-term follow-up and what happened to these patients. And the key message from this updated work is that after 5 years of follow-up, the improved overall survival with CPX-351 versus 7+3 was maintained, which support the previous evidence that CPX-351 can contribute to long-term remission and improved overall survival in patients aged 60 to 75 with newly diagnosed high-risk or secondary AML. You can see here in the overall population, the overall survival at the 36 months, 3 years mark. You can see 21% versus 9%. We're dealing with a hazard ratio of 0.7. So definitely 30% improvement in the overall survival in favor of CPX-351. And if you consider the patient who were able to proceed to allogeneic stem cell transplantation, and we'll come to this in the discussion, you can appreciate that this is quite important and interesting to see this significant difference, 0.51, almost 50% improvement in favor of the CPX-351. So for the purpose of this journal club, it is my great pleasure to welcome two famous and brilliant panelists. The tradition is always to have a co-author of the article and an expert who is not a co-author, to have a sort of outside opinion. So here I have Professor Thomas Cluzeau, who is the head of the hematology department at the University Hospital of Nice in the south of France, a beautiful city with lovely weather on the French Riviera. And I have also Dr. Stephen Strickland, who is an assistant professor in charge of the myeloid malignant hematology at the Vanderbilt in Nashville, and he is a co-author of this lovely work. So Stephen, congratulations for this really fantastic publication in the Lancet Hematology. And thank you for joining us today, despite a very busy schedule. I know it's in the middle of the day for you, in the middle of your clinic. So my first question is going to be to you, Stephen, about, can you just remind our audience, and here I would like to kindly invite all of you to send your questions, your comments, and I'll do my best to share them with our experts. So can you please, Stephen, remind us exactly what is CPX-351 and what is the rationale, the idea, the science behind this drug?
Sure. First, yeah, obviously, thank you very much for having me. It's an honor to be able to participate in this with all of you. So, um, the CPX-351, or also known as liposomal daunorubicin and cytarabine, is basically a repackaging, a reformulation of our traditional medicine that we've used, as many of you know, for years and years. So the daunorubicin is the anthracycline and the cytarabine as the nucleoside analog, and basically it had arisen from the idea of if we can repackage this and place these two drugs in a fixed molar ratio inside of liposome, can we improve delivery of the medication? There is some preclinical data which suggests that this formulation may actually be better taken up by the disease cells. And so we may actually, although it's not a targeted therapy in the conventional sense of the word, are we actually hitting our target better with this conventional anthracycline and cytarabine based product? And so I think there was a lot of concern that would simply repackaging this have such a difference. And thankfully, it did. And we have seen the effect of it. So I think there may be more to learn about the drugs that we've used for years about improving upon those and not just novel mechanisms, which we do need, but also, can we improve the current therapies that we have just by looking at it in this light?
Excellent. Thank you very much. So it's a sort of a novel generation conventional chemotherapy, sort of a modern version, which is quite interesting, actually. So, Thomas, you are not part of the study, but you have really great experience with the use of CPX-351. And I believe you published recently a large series, multi-center retrospective series from France using CPX, and that was very nicely presented at the last ASH meeting. So what was your reaction when you've seen this paper, when you read it and you saw these curves, survival curves, and the updated data?
So thank you, Mohamad, for inviting me to discuss this paper. So we were waiting this paper because we had access only to the first publication from GCO, and of course we were very happy about the results of the CPX in this high-risk subgroup of acute myeloid leukemia. But the question was, maybe we just delay the relapse. And with this publication, we can say now it's not the case, because we observe a plateau in this subgroup of patients, and usually in this high risk of patient, there is no plateau, and we observe in not transplanted patient 20% of long survival. And the most important for me is in transplanted patient. So in our French experience, and also in Italian experience recently published, the transplanted patient had a really good overall survival. And in this paper, the median overall survival is not reached. So it's really good with a very long follow-up. So maybe we could say with CPX-351, we could cure some patients with transplant after CPX-351, and in this very high-risk population.
So here you're bringing an important, I think, issue, Thomas, and I'd like to ask Stephen. It looks like that, if I can read between the lines, what you said is that, well, obviously you have 20% of long-term survivors without transplant, which is maybe viewed great or insufficient. But at the same time, in secondary leukemias, high-risk leukemias, we are seeing over the long term in the transplant group really impressive over survival. So does that mean, Stephen, that actually we should deliver intensive chemo similar to CPX-351 to all our patients? Well, because this is a crucial question today, because every day you go to a leukemia meeting, actually we're talking now about the mild, gentle, reduced intensity regimens with venetoclax, hypomethylating agent, pevonedasta, magrolimab, all of these new novel agents. And here we're talking about like, having a sort of an old dogs with new tricks, I would say.
Yeah, I think it's a great question, and I wish I could give you a straight yes answer or a no answer and make it easy. But in the world of leukemia, as we know, everything is very complicated. Since 2017, we've all of a sudden had so many more tools in our tool chest, or weapons in our arsenal, whatever we want to say, in order to attack acute leukemia with now. And this is one of those. I think that, for those patients who are candidates for intensive induction therapy, based on the data that was generated and based on the study population, I think that this is a very useful tool in an otherwise high-risk patient population. Seeing the remission rate, improved remission rate compared to conventional 7+3, seeing the overall survival advantage in this patient population that we know historically has not done well. So again, the label for the medication is open in the sense that it doesn't have a specific age range. Obviously, the study was done in patients aged 60 to 75. So then that draws into another question of how do we apply it. But for these patients who biologically have the MDS related, the therapy related, or CMML related leukemia, acute leukemia, I think this is a very viable option. Now it's harder to say whether or not this should be used instead of a lower intensity regimen. Obviously, the results with the venetoclax-based therapies have been very impressive, and it gets us all wondering and thinking. But in the absence of having head-to-head data and knowing that the two study populations were quite different as far as the way the trial was designed, I don't know that we can say one versus the other. But I think for patients who are definitely induction candidates, especially if they're going to be potentially transplant candidates, given the benefit that really seems to be separated out amongst patients who receive CPX and then are able to go on to transplant, I think it's a very appropriate and viable option.
So thank you, Stefan. This is a very important comments. Thomas, in your experience today, who would you consider as the most appropriate patient candidate to receiving CPX-351 versus the traditional historical 3+7 versus the other intermediate intensity combination or low intensity combination? I know there are no strict guidelines or universal consensus, just from your practice empirically, I would say.
So yeah, so today in my practice, I think the best population for CPX-351 is patient eligible for allo stem cell transplantation, because I think the question today is how I can obtain a deep CR before allo stem cell transplantation. So CPX is of course a really good candidate to obtain the aim, but today, as you said, we have access with a new available drug or drug available only in clinical trial, has venetoclax, has maybe some inhibitors depending of the presence of some mutation, has some immunotherapy. So I think that there is there is a challenge to find the best way to obtain a complete remission with maybe negative minimal residual disease before allo stem cell transplantation to obtain the curve we observe in this paper. So today, I think the best population is the patient eligible for allo stem cell transplantation, but we saw in the publication patient not transplanted had a plateau around 20%. It's not really good, but it's good in this high-risk population. So maybe the best way is the clinical trial recently presented at the EHA meeting, combining CPX plus FLT3 inhibitor or IDH inhibitor. So today we have access only on the safety data, but maybe in the future it could be maybe good combination to increase the results in a subpopulation mutated for FLT3 or ADH.
And actually, you have already answered one of the questions we have received, whether we can combine CPX-351 plus FLT3 inhibitors. And actually, you already answered that it is feasible. Now, we don't know what would be the long-term outcome, but there is a scientific rationale for this, and there are some preliminary data about this. So, Stefan, I think Thomas raised the issue of MRD negativity prior to transplant, and we know that this is a crucial parameter for the long-term outcome. And obviously, MRD wasn't assessed in the study. Maybe some patients had MRD being assessed, but that wasn't part of the goals of the trial. But then, given the very high level of survival and the plateau, it is likely that many patients actually were really in a deep response status. So, in another word, we believe, and this is probably a confirmation, that in order to deepen the response, you need intensive chemo. But on the other hand, we know that intensive chemo may actually debilitate the patient and may not put the patient in the optimal configuration to proceed to transplant. So what is your experience with this drug? While on one hand you have intensive chemo, but on the other hand, how is the safety profile in order to bridge these patients to transplant?
Yeah, I think it's a really good question, and I think that one thing that would be ideal is if we had better sort of predictive scoring systems at the time of diagnosis prior to the initiation of chemo in order to help us understand. And there's a variety of calculators or prognostic scoring systems that are out there to try and help us utilize tools, but there's not one standard approach, whether it be the AML score, the Wheatley index, or the comorbidity index that transplant programs use. Like, how do we identify those patients that we think can truly handle the induction therapy? And at this stage, I think it's in part, kind of once you're in the middle of it and you see what toxicities do or don't develop. So, I think that the challenges of induction therapy are, not only getting it in remission, but as you alluded to, having the patient be strong enough and have an adequate performance status at the end of induction that they're still a candidate for intensive therapy. In my experience, when the patients that we give VYXEOS2 or CPX2, they tend to do fairly well, and sometimes they tend to tolerate it, in my experience, better than traditional 7+3. Now, whether or not that has to do with the liposome, I think it's unclear. We know that, interestingly enough, most patients don't have alopecia when given this formulation, and hopefully the cardiac toxicity is less. So maybe it's safer, but I think we have some question marks there. In regards to MRD, unfortunately, as you mentioned, this study did not collect those samples and do a central MRD testing. It would have been ideal in retrospect. I believe that the presumption based on the improved outcomes that we're seeing in the transplanted population is that that we are in fact achieving deeper remissions. I think that data will be hopefully forthcoming to see and assess the level of MRD negativity that is actually achieved with CPX, and if that is the rationale and the explanation as to why we're seeing those improved outcomes. But unfortunately, we still have more data to be discerned and reported.
Excellent, thank you. So, Thomas, do you share the same positive feeling about the very good safety profile despite being an intensive chemotherapy?
Yeah, I totally agree with maybe a better safety profile. So in my experience and in the French cohort recently published, we observe a better safety than we observe usually with a 777. So it seems there is less GI side effect, less skin side effect, and of course less alopecia. And in the clinical trial published, the phase 3 clinical trial published, there is more patient undergo to allo stem cell transplantation in the arm treated by CPX-351. So there is more patient because there is more patient in CR, but also I guess there is more patient because also there is more patient with a good safety, so more patient maybe in better condition to undergo to allo stem cell transplantation.
Excellent. And I guess we will have more and more patients who are able to proceed to transplant now, having more and more donors available, because obviously we need to remember that this trial is from the December 2012 to November 2014. So this is the beginning, I would say, of the boom of the haplo donors. So we have a few questions, Stephen, about how to perform consolidation when using CPX-351, because we spoke about the induction regimen. So do we use the same schema, the same drug for consolidation? How do you handle this from a practical point of view?
Yeah, I think that's a great question. And I'll admit it's one that I do struggle with at times. I think that there's a number of different ways to go about it. Obviously, in the study, the patients continued to receive CPX as the consolidative approach. And in that context, they received on days 1 and 3 instead of the days 1, 3, and 5 that they received during induction. And so based on that data, I think it's very reasonable and appropriate to utilize that format consistent with the way the study was done and based on those outcomes. That being said, we have years and decades, honestly, about using high-dose cytarabine. And then there's always that question, especially for patients who have therapy-related disease and have potentially received prior anthracycline. When do you get to the point of the anthracycline max, and is it safe from a cardiac perspective, especially if we're going to potentially take these patients to transplant? And so I find myself sometimes doing a balancing act of whether to continue with the CPX from consolidation as the study was done. But admittedly, there are cases where I will switch over to a high-dose cytarabine consolidation in that format. I don't have the data, and so this is opinion. This is not based on the data, and I'll be totally transparent in that regard. But I think just practically speaking, we find ourselves, again, maybe in those patients who have had prior anthracycline exposure where we maybe don't feel comfortable continuing to challenge them with more anthracycline. And so I think it's a combination approach. I'd be very interested to hear what my colleague and uses as well.
And I think your comment is very well taken, because we need to be fair. We have a lot of uncertainty about the value of anthracycline used in consolidation. And actually, if you use CPX, automatically you have no choice. You are giving cytarabine and anthracycline. How would you do things, Thomas?
So yeah, so in the usually I try to continue to use CPX-351, but yeah, for in the French experience, we observe that some center consolidate the patient with intermediate dose of cytarabine. I would like to add maybe something to discuss. But now, as you know, CC486 are available after intensive chemo in patients in CR, and CPX-351 is an intensive chemo. So I think this drug could be used after CPX-351. Today, I have no experience after CPX-351, but maybe we could propose as maintenance therapy this drug. So I don't know, what do you think about that? But maybe I think it's not off-label, and maybe we could use also this drug after consolidation, or maybe after induction, if we can continue with consolidation.
Actually, here, Thomas, you're bringing into the podium several questions we're receiving. How can we combine CPX-351 induction plus all the novel agents? And you're alluding to oral azacitidine, I think, as maintenance. And by the way, the paper, the pivotal paper about oral azacitidine published in the New England Journal of Medicine has been discussed in this journal club a few months ago. So I'm glad you're bringing it here. And this is amazing, actually. So let me throw the same question to Stephen. Would you envision, because we have a couple of questions from the audience, is, well, after induction and achieving complete remission, what kind of consolidation, non-cytarabine, no high-dose cytarabine, because the patient, doesn't want to get into the hospital, would you see maintenance treatment with azacitidine, venetoclax, or oral azacitidine, as mentioned by Thomas?
Yeah, I think it's a great point, and just to clarify and agree with Tomas as well, I said high dose, but I should have said probably age-adjusted high dose or intermediate dose cytarabine given the age range. But I do believe that if patients are not eligible for consolidation chemotherapy due to other comorbidities or toxicities, performance status, I think in that population now, with the availability of the oral azacitidine, I believe that that's a very reasonable approach to try and maintain control and really maximize the duration of the disease control. And also, even for those patients who do go on to receive consolidation therapy, and if once they finish, if they are not, for whatever reason, a transplant candidate, again, due to comorbidities or lack of a donor, although lack of a donor is less and less likely to happen nowadays. But I do think that the maintenance with the oral azacitidine is very appropriate in that context. So I would, many of these patients as well may have MDS-related or therapy-related disease, and historically a population that we would have used azacitidine approaches in. So I think that for multiple aspects, it potentially has a role in helping to maximize the duration of control.
Excellent. Thomas, we have a question here. For a young, fit patient with secondary AML and complex karyotype, how would you sequence the appropriate regimen? Would you go for CPX first, followed by, and if it fails, you go to hypomethylating agent and venetoclax, or you would start with hypomethylating agent, venetoclax, and if you fail, you salvage them with CPX? Is there any sequence here you can see?
Yeah, so for the younger patient, it's difficult to answer. I would like to treat first the patient with more intensive chemo, so like 3+7 or CPX-351, so more CPX-351, and at relapse, yes, I will use azacitidine plus venetoclax. So but I think today, as you mentioned, the population was between 60 and 75 years old, but I think we could maybe extrapolate to the younger population, but I think we need more data about younger patients. And today there is a German clinical trial ongoing evaluating CPX versus 3+7 in younger population, and also in intermediate and adverse ELN risk. So maybe we could answer to more question. I think maybe with the results of this clinical trial.
Excellent. Thank you very much. We have another question from Dr. Andrius Susenska. Hopefully I'm pronouncing it well. If you have a patient you would like to bridge to allo transplant, and this patient has received CPX-351, achieved complete remission, and I would personally add MRD negativity, do you feel that you need to give consolidation or another cycle, or you just proceed to transplant if the donor is available? Stephen?
So I think it's a great question, and one that I don't know that we have definitive data as to how much consolidation is needed, especially when a donor is available. You know, and the logistics that we sometimes run into, I know at our center, is even when the patient's documented to be in remission, it can often take, 6 weeks, sometimes 8 weeks, especially if it's an unrelated donor, from the time of saying they're in remission to actually activating the process, getting the donor collected. And now in the era of COVID, that has changed timelines, I think, for all of us in regards to stem cell collection. So many times I will, in parallel, kind of activate the process, have them meet formally with the transplant team, go through that donor activation, but we may give a cycle of consolidation while we're waiting for that, because again, usually they can get the therapy and recover from the therapy while waiting, and to try and minimize the chance of them relapsing while we're waiting for the donor to be activated and collected. So we often will squeeze in a cycle even if we have a donor during the logistics of all of that. Obviously, if we're still waiting for a donor to be identified, we would continue with a cycle or two, and then try to go from there.
Thomas, do you apply the same approach in Nice?
Yeah, I think if we obtain a complete remission with a negative MRD, and if we can proceed directly to allo stem cell transplantation, I think we will do that. The question maybe more challenging will be if your patient is in CR without negative MRD, and you can proceed allo stem cell transplantation. Do you want to perform maybe a new consolidation to obtain the negative MRD before allo stem cell transplantation, or we go directly to allo stem cell transplantation? I have no the answer at this question, but maybe it's something to evaluate. Why not?
Excellent. And here we have actually, you answered the question from Dr. Burgess about whether we had MRD data after CPX induction in this trial, and unfortunately we replied to this that MRD wasn't available. But remember, the trial was performed between 2012 and 2014. So here we're talking about the long-term follow-up. We're reaching the end of this fantastic journal club, guys. I hope everybody has enjoyed the discussion. Again, Stephen, congratulations for really beautiful work, and congratulations for something which I think is extremely important in our field, which is about the long-term follow-up of our protocols. So here, I would really invite all colleagues and friends and all clinical trialists, please do not forget to give us the long-term results of your protocols, because this is extremely important to design future treatments and protocols. So thank you very much, Thomas. Thank you, Stephen. Wherever you are, I hope you have enjoyed it. Thank you for being loyal to the IACH Journal Club. We have plenty of ongoing activities as part of the IACH. You may have noticed probably that we have launched a couple of weeks ago the weekly IACH news, where every week in short podcasts, 5 to 10 minutes, you have a summary of some novel data, of an article, publication, whatever, press release being analyzed by expert in the field. So please watch, look into your email box for the IACH news. Regarding the journal club, our next journal club is going to be in 15 days, and then we'll take a sort of a summer August break. But please don't forget that we'll start back early September again, and we'll have the IACH annual meeting, which is going to be this year in a virtual format. But for the time being, I hope everybody's doing well, and wherever you are, please stay safe and keep well. Goodbye.
Bye.